We're going to talk about the management of myeloma for frontline therapy for newly diagnosed patients. So here's a case that we'll ask your input on. 65-year-old concert violinist initially presents with increased protein. Her doctor decides to do some testing, and she's diagnosed with high-risk smoldering myeloma. She declines a clinical trial, as she has a busy concert schedule and is asymptomatic. 4.5 years later, she now has progressive fatigue and is anemic with a hemoglobin of 9. And as you heard from Dr. Cole, she's diagnosed with symptomatic myeloma, revised ISS stage 2. So the question is, which of the following are correct? A, she should have started treatment 4.5 years ago. B, she should decline treatment now. C, she should start with bortezomib, lenalidomide, and dex and must stay on it until stem cell collection. D, potential impact of neuropathy on her career is an unfounded concern. Or E, none of the above. All right, so let's see what the right answer might be. So a fair number said she should have started treatment 4.5 years ago. Then we have RVD or VRD, and then some said none of the above. So let's see if we can converge those answers. So there's a lot of factors to consider in deciding initial therapy. I would argue this is not just true of myeloma, but all cancer, but we have to think about patient factors, disease factors, and treatment factors. So in the patient box include what's the patient's age, and there's this whole evolving field in oncology of geriatric oncology. The fact that this is not just somebody's chronological age, but how fit are they? The performance status, which kind of gets to, how active is the patient. In this case, we had a patient who was a busy violinist and traveling, kidney function. What are the other medical problems like neuropathy, heart issues, diabetes, low blood counts? And as you heard, although myeloma is a heterogeneous disease, most patients are diagnosed in their mid-60s, which means that a lot of these other conditions could have developed by then. Although at Sinai, our youngest patient was diagnosed at age 18, and our oldest is over 100, which is why this patient box is so important. You can't treat that 18-year-old the same way you would treat a 100-year-old. Then we get to disease factors. So what is the burden of the disease? Are the proteins rising quickly, or is this somebody who's relatively flat? How much myeloma involvement is there in the marrow? Because that's going to potentially affect your blood counts and how aggressive you can be with therapy. Do they have any of those crab symptoms that you just heard about? Do they have disease outside of the myeloma, outside of the marrow, which is considered extramedullary or outside of the marrow? And that can be very aggressive. And biology of the disease, what is the molecular features of this patient? Do they have deletion 17p, 414, as you heard about? And last is treatments. Has this patient been treated before? If so, what was their response? What side effects did they have? We now have the privilege in myeloma of having a lot of choices of how we give drugs, orally, intravenously in the skin, so that's nice. So the route of administration can be different, whether it's single agent or combination therapy, and an increasing issue all over the world, but I've been in countries recently where they don't even have access to some of the drugs, or some of the drugs they do have access to is only for a fixed duration of time. And here in this country, we currently have a little bit of a reprieve from that, but the costs, as we all know, out-of-pocket copays are quite challenging. So what are the goals of initial therapy in a newly diagnosed patient? Well, we want to get a very good partial response or better, so we're able to get deep responses. What is the overall response rate, and is it going to be rapid enough? Especially, let's say, if somebody has concern for affecting the neurologic system or kidneys, we want a response very quickly. Will this patient feel better? We heard that our patient in this case was really tired. Can we help their quality of life? And minimal side effects, because again, like in this patient, she was concerned appropriately about her neuropathy and the ability to play. And we also, of course, we want to prolong overall survival, but not at the expense of quality of life. So this is the same checkbox that we would argue are important for patients to consider when looking at a newly diagnosed patient being treated. What are the options to be considered? You heard from Dr. Cole very well about the lab values and tests that are important to track response and monitor side effects. Clinical trials, you'll hear over and over again from the panel about why that's so important. But is there a clinical trial that might be appropriate? And can you bank your marrow? And this is a good idea when somebody's being worked up for myeloma. It's good to get the marrow done once and done properly with all the testing rather than undergoing repeat testing. So briefly, before we jump into myeloma, it's important, and you heard from Dr. Cole a little bit of these distinguishing factors. We have the MGUS, which is not an active cancer. Then you have smoldering myeloma and active myeloma. And you've heard about these new myeloma-defining events, which are listed at the bottom, which is if there's a lot of bone marrow involvement, more than 60%, if the free light chain ratio is greater than 100, and if they have more than one lesion on the MRI. Those are considered now myeloma-defining events. And theoretically, even if a patient did not have CRAB symptoms, they could be considered active myeloma and warrant therapy. Well, that seems straightforward, and this is from our work showing maybe it's not that straightforward. And it's a busy slide, but I'll call your attention to the middle part, which is about the free light chain ratio. So there were two studies done initially from the Mayo Clinic in Athens, which put the rate of progression, if you have a patient with newly diagnosed myeloma and their free light chain ratio is greater than 100, they found that at 2 years, the risk of progression was 72%. And then a subsequent study showed 98%. So that was the reason that this was reclassified, because if the likelihood of progressing is so high, why are we waiting, and why don't we treat people earlier? But then the data get more interesting. We have the Penn group came out, and they said that they're only 64% progressed. This Danish study, which is published from Europe, said only 30% progressed. And in our own study, which we just completed, we only saw 52%. This is a big deal, because if we say that we should be treating everybody with free light chain ratio greater than 100, initially it seemed like an appropriate decision, but now maybe we need to think about that more closely, because if 50% of patients are not going to progress, does everybody need to be treated? And that's really important, because if this patient that we saw had been treated 4.5 years ago, the reason that she would be assumed to be alive and well at 4.5 years later would be, say, due to the treatment. But what we know from her case, it was nothing to do with the treatment. That was her disease. So our data suggests that what we always tell medical students, don't treat a number, treat the patient. So it is possible that somebody may have a free light chain ratio greater than 100, but if they've already been asymptomatic for 3-4 years, by definition, they've passed that high-risk period. Because the real concern is that first 2 years, who's really going to progress quickly, so we're not sitting on them and not starting therapy. So I would argue that in smoldering myeloma, this is perhaps one of the areas that's most important to get a second opinion, because you will see a divergence of opinion. And consider if no immediate treatment is required, you can be monitored closely. Consider bisphosphonates if somebody has osteoporosis. But really, clinical trials are probably the best way of dealing with this, because when you're seeing such divergent data, we really don't know what the right answer is. And that's how we advance treatments in myeloma. Now moving to somebody who has active myeloma like our patient, we use typically 3 drugs for induction therapy. We'll go through a little bit of why that is. We want to get deep responses. And in somebody who's definitely below the age of 70, many centers will consider appropriate for transplant, but there are plenty of centers, including our own, who've done transplants even up into the 80s. Medicare will pay for a transplant up to age 80. So it really goes back, and you'll hear more about transplant from Dr. Krishnan, that the role of transplant is evolving, but age is not an end-all and be-all for deciding whether somebody is a transplant eligible. So in terms of what drugs we have right now for myeloma, there's basically these 6 categories of drugs that you see here: steroids, conventional chemo, IMiDs, proteasome inhibitors, HDAC inhibitors, and monoclonal antibodies. I'll take a moment to say that this progress is really unprecedented. We had 10 drugs, as you heard, approved in the last decade, including 4 in 2015 alone, in a cancer that's dwarfed by breast, lung, prostate, and colon. Those are the big 4 cancers. To have 4 drugs approved in a year is really remarkable. And that's only possible because of you all in the room, patients and their caregivers, the healthcare teams and our collaborating institutions, pharmaceutical companies, the FDA, and who brings this all together, the MMRF, MMRC, because we need somebody to lobby for patients and get these drugs approved. And it's with all of that collaboration that this has been accomplished. But now, when you have so many drugs, which ones should we use for newly diagnosed patients? And I've circled basically the drugs that are most commonly used for newly diagnosed patients. We have everybody's favorite, steroids, cyclophosphamide, thalidomide, lenalidomide, Velcade, and Kyprolis. So those are the drugs that we're going to play around with. And as you imagine, we're not going to typically combine drugs within the same category, because you're not really going to get much more bang for your buck. So we're going to try to combine drugs from these different categories. And the most common combinations are listed here. So first question, is somebody a transplant candidate? If so, we want to try to avoid using drugs that could impair their collection. And typically, we want to give 3 to 4 cycles of induction or initial therapy. And the goal of that is to try to get rid of the myeloma quickly, get rid of those CRAB symptoms, and make sure that the marrow has been cleared adequately so that we can go to collect the cells. Because if you try to collect cells in somebody who's newly diagnosed with a marrow packed of myeloma, you're not going to get very much. So we want to do that, the appropriate initial therapy. And there have been, I'm not going to show you all the data because I think it tends to be a little wonky and data heavy, but suffice it to say there was a very important study that came out this year that 3 drugs were better than 2. Velcade, Revlimid, and Dex, VRD, showed better responses than RD. And it's surprising because in U.S. we've been doing that regimen for almost a decade, but we didn't have this phase 3 study. But now we have evidence that with the VRD, people had better response rates, meaning deeper, they lived longer, and their duration of myeloma remission was better. So all of those endpoints that we look for, response, progression-free survival, and overall survival, were superior. There was a European study that showed that Velcade thalidomide index was better than Velcade cyclophosphamide index, particularly for depth of response, and another Italian study that showed that Kyprolis Revlimid index was better than Kyprolis cyclophosphamide index. So really you can use a lot of those, but clinical trials are always a great idea. We have a really interesting study now where we're combining daratumumab with RVD versus without to see if we can improve beyond VRD, which is the kind of backbone that many of us use. And then you go to transplant. Now, if somebody's not a transplant candidate, then what do we do? You can certainly use all the regimens on the left, and I'll talk a little bit more about that in a second, but there's also, you can use 2 drug regimens. If somebody's very fragile, maybe we don't want to beat them up as much with the heavy drugs, so Revlimid or Velcade with steroids. But I would argue, and that's what's nice about treating myeloma, that these drugs are not super toxic. And when you pick the right dose, the schedule, and the frequency, you can make these regimens tolerable. And we've been doing so-called VRD or RVD light for even older patients. And it's just because somebody's older or more fragile doesn't mean that they don't need that rapid response, get faster improvement in pain and improvement in their quality of life. But clinical trials are ongoing for the best regimen for older patients. After they've been debulked, whether it's with initial therapy or with transplant, there's discussion of maintenance. And the blue bar at the bottom is very important, which is supportive care throughout the continuum is important. So we want to help pain, quality of life, bone strengthening. All of those things are important to deal with. The important answer, though, is there's no one right answer for every patient. And that's, again, where second opinions can be very helpful. So in preparing for myeloma therapy, what are the things that we are thinking about? We want to look at the treatment choices. What are the risks and benefits of each? What can we do to prepare for treatment? How will this affect your normal life? And this patient we had was traveling quite a bit. What are the side effects? How to minimize those? What resources are available for the family? I've noticed that there was actually at UCLA now when I graduated 20 years ago, we had a class called Doctoring, which was, and the title was, Is it cancer and can I still have sex? The 2 questions that most patients had and were afraid to ask. And part of what they talked about in that class is that 50% of what we tell a newly diagnosed patient goes in one ear and out the other, and especially in that first visit. It's super important, and it's great to see so many caregivers here because a lot of this information can be overwhelming, and it's great to have somebody say, what did they say? And so you have that backup. And how to get in touch with questions or emergencies. So a little bit about the drugs. And the drugs you'll hear are divided through the program today, and depending on what category they're used in terms of what stage of disease. So I'll take a couple of them, which is Revlimid in frontline therapy. It's approved in combination with dexamethasone in newly diagnosed patients, and recently was approved also as maintenance post-transplant, although typically given at a slightly lower dose. This is an oral medication, which is great and convenient. It's typically taken 3 weeks on, 1 week off. It's very important to take blood thinners to prevent clots, and we'll talk a little bit more about that. And so what are the possible side effects? And so what you have here are not only side effects, but the important thing is how to manage them. Unlike other diseases, so you could ask, why aren't these drugs given by primary medical doctors? And the issue is in oncology, our drugs have what's called a narrow therapeutic index. If you give too much, you're going to cause problems. If you don't get enough, the cancer won't be treated. So we need people who specialize in these side effect and treatment managements to adjust the dosing and schedule. So for blood clots, we can give medications to prevent. Revlimid can reduce your blood counts, but we can adjust the dose of the drug and also give drugs like Neupogen to increase their blood counts. If patients can have a rash, but we actually recently published a paper that unlike other types of rashes, you can give Revlimid and pomalidomide and thalidomide safely with concurrent steroids. So rather than giving all the steroids Dex once a week, you can give lower doses sprinkled throughout the week and give it with drugs like Benadryl or Claritin. Fatigue is a big issue with myeloma, and that's going to be difficult to tease apart whether it's the Revlimid, the blood counts, or the disease itself. Some patients complain of muscle pain and cramping, and coconut or tonic water have been helpful. Diarrhea is an interesting one because there's actually a publication that a bile sequestrant called Welchol can help with Revlimid diarrhea. So that's important to know about. And we now know that Revlimid, particularly when given after transplant and melphalan type of drugs, there is a slight increase in secondary cancer. So it's important, just because somebody has myeloma, that they don't neglect the rest of their body, and keep up with mammograms, colonoscopies, whatever you're expected to do. And especially, as you heard from Dr. Cole, people are living longer and longer. So it's important to stay on top of all of those other medical issues as well. So Revlimid and pomalidomide and thalidomide, about 20% of patients who take them with steroids will get a blood clot. And so it's really important to prevent it, because prevention is much easier than treating a clot. Other drugs can increase the risk of clots. As I mentioned, steroids, drugs that increase the red cell production like erythropoietin, if somebody's had a prior blood clot. Other risk factors, including not being as active, obese, if you have a family history of blood clots, if somebody's post-operative, so especially orthopedic procedures, it's a big problem with those patients, even aside from myeloma, but when you're on Revlimid, the risk is going to be higher. Long car rides, plane flights, so we recommend to our patients who are taking those to always let us know so we can sometimes give an injection that the patient can self-administer on days of long flights, such as from Amsterdam. And also the presence of a catheter it can increase the risk of clots. So the options are aspirin. A baby aspirin usually is adequate, sometimes for higher risk patients, low molecular weight. And there are not necessarily published studies, but we've been doing some of the new oral drugs as well for blood clot prevention that you've probably heard about on TV that have the advantage of not requiring monitoring. Moving to Velcade for newly diagnosed patients, it's approved for relapsed myeloma initially in 2003 and then newly diagnosed in 2008. It can be given either intravenously or under the skin, but generally we prefer to give it under the skin. I know for those who are conscious about the summer bikini bodies, they can cause a little bit of redness under the skin. The problem is, though, that even though it's cosmetically not as appealing, the other side effects are much less when you give it in the skin relative to IV. And the reason for that is when you give it IV, the drug gets into a very high concentration into the blood, whereas when you give it in the skin, it gets released slowly. And even though it's released slowly, the efficacy is the same, whether you give it IV or sub-Q, but the toxicity is much lower when you give it in the skin. So for that reason, we generally give it in the skin. But some patients do really prefer to not have that skin issue, which is typically transient. What are the side effects? Peripheral neuropathy. This is what that patient was concerned about. These drugs can cause nerve damage, including numbness, tingling, sensations. And it's very important as patients you be in close communication with your healthcare team about these symptoms, because we can adjust the dose of the Velcade. We can give it weekly instead of twice weekly. We can make sure it's given under the skin. We can adjust the dose. So that's one of the main reasons to be monitored after every cycle of therapy initially, to see how people are tolerating this. Low platelets can occur, but typically that tends to be diminishing frequency as the myeloma is under better control. There's GI side effects like nausea, vomiting, diarrhea. That's very patient-specific. I mean, some patients are constipated, some patients have diarrhea, so it immediately tells you it's really very patient-specific, and there are a lot of medications that can be used to do that, give with that. Fatigue, rash, we talked about the rash in the skin. Very important, all the drugs in this class can all reactivate shingles. So 20% of patients who get bortezomib or Velcade, Kyprolis or carfilzomib, and the new drug ixazomib, Ninlaro, all of those can increase the risk of shingles. So it's very important to take a preventative pill. A lot of people ask about the vaccines, and you'll hear more about this in supportive care, but the historic shingles vaccine was a live vaccine and not approved for patients with blood cancer. The newer vaccine is not a live vaccine, but we don't yet have data. So, but stay tuned. We hope that that'll be approved soon. How to manage peripheral neuropathy, we talked about this, but in terms of the dose and schedule, but things people often want to know, what else can we do? We check vitamin B12, B1, and carnitine levels, and we found that sometimes replacing those can be helpful. The medications that are approved for neuropathy, such as Neurontin or gabapentin, Lyrica, can be helpful for patients. And again, it's very important to be in close communication with the medical team. So now that we've picked our initial 3-drug regimen, so for our patient, the RVD seems a typical evidence-based approach to start with, 3-drug regimen. How do we know if it's working? And so if you start at the very bottom, obviously if the numbers are getting worse, that would be progression of disease, which is almost unheard of now with newly diagnosed myeloma because the treatments are giving nearly 100% response rate. Stable disease means there's not much change. And then we get into what we really want to see, which is partial response is 50% drop in the proteins that you heard about in the blood or 90% in the urine. Very good partial response is now 90% reduction in blood and very low levels of protein in the urine. And everything above that, really, you should have no more measurable M protein. So that's the first thing that we're looking for. But then how do you distinguish, especially with these new drugs, if everybody's having a good response, how do you know if adding a drug is going to give you any better depth of response? And so now we need to look at the other things on the right side, which is the immunofixation is now negative. So not only can we not quantitate the protein, we can't even detect it anymore on that faint band by the immunofixation. The bone marrow is used particularly in clinical trials to confirm that we've had a complete remission, that we can't see myeloma anywhere, not only in the blood, urine, but also in the marrow. And what's not on here is imaging. Imaging is also important to help confirm a complete response. And then the free light chains, that last one on the right, which should also be negative. And so visually, what's happening is that we'll have actually a hot topic about this minimal residual disease later, but if you think about this as an iceberg, it's very easy to see at the very high levels that the myeloma is just jutting out of the water, and we want to knock that down quickly. But once you've gotten to the water level, how do you know what's lurking below? And that's where you start to get to these newer tests, getting to deeper levels of response. And to truly get to those very, very microscopic amounts of disease, we need what's called minimal residual disease testing, MRD. And we'll talk about some of the pros and cons of that. Those can be done by genetic testing, PCR-based, or by another method called flow cytometry. And this is important because, it's almost like an arms race. When you only had 2 drugs, this was not a relevant question of minimal residual disease. But when we've gotten now that huge table of drugs, we've gotten better at getting rid of the myeloma. So now our diagnostic techniques have to keep up with the therapeutic techniques to see how much better we're getting in terms of eradication of disease. And so in terms of maintenance therapy, for this patient, for example, let's say we do RVD and we get her into remission. Should we stop or continue therapy? And this is where myeloma is different from every cancer is different, but most patients with myeloma, if you stop their chemo, the numbers would tend to come back within about 6 to 9 months. It's not that it would come back to the full-blown level, but this is why in some ways, we talk about these cancers as chronic diseases. Just like if somebody had diabetes and blood pressure, if they were to stop their pills, those conditions would go uncontrolled. In myeloma, it wouldn't happen necessarily the next day, but we can see that continuing low doses of therapy generally have shown in studies to be better than stopping therapy because you keep with the low level of therapy the myeloma in remission. But again, it's always a risk-benefit question, and so we have Revlimid has been oral and available for a long time, so that has a large body of data for maintenance. Velcade has been a little bit more challenging because it's been injecting, but for certain patients, like 414 patients, 17p has been shown to be very helpful. And then now there's data, but we don't have enough of it, but the oral proteasome inhibitor could be really important for maintaining remissions with that class of drugs. And so what are the studies that we're doing now for newly diagnosed patients? On the very left, you have smoldering myeloma, and there's a whole host of studies there that are possible. For initial therapy, RVD, we're trying to see if we can do better than that by adding drugs like Darzalex, Implicity. For non-transplant patients, often in Europe, this study actually just got high-level results that the addition of DARA to Velcade, melphalan, and prednisone resulted in improved outcomes in Europe relative to those who didn't get it. And then there's the maintenance that we talked about briefly as well. So to summarize, smoldering myeloma, which is the absence of CRAB symptoms and the myeloma-defining markers, I think the main thing is to make sure that the disease is monitored closely, consider a second opinion. If particularly somebody's high-risk disease, consider clinical trial participation. To that point, low-risk patients are not appropriate for clinical trials because generally they're going to do so well. We'll be sitting on them for years and we're not going to see any evolution. So we really need to pick the right population to study for smoldering. Symptomatic myeloma, triplet therapy seems to be the way to go in 2017. Stay tuned for further data. There was a study, and you'll hear more from Dr. Krishnan, that the consolidation of this initial therapy with a transplant seemed to result in better outcomes than those who had a delayed transplant. You'll see continued maintenance and consolidation data And very important that the side effects of therapy can be managed as long as there's close communication between the patient, caregiver, and the healthcare team. Please come with all your side effects that you're experiencing. And clearly, clinical trials have paved the way, and we continue to see improvements across the disease spectrum. So with that, thank you for your time, and happy to take any questions.
Thank you very much. I have a couple questions. I've got 3 questions on the same thing, which tells you it's very much in people's minds. Dexamethasone. Why do we use it? Why does it work? What's the dose? And how do you deal with the side effects?
It's a great question. And I think this is a good example of patient advocacy. So before, when we had 2 drugs, which was basically melphalan and steroids, dexamethasone would be often given in 40 milligrams for 4 days pulsing, so 4 days on and off. 40 milligrams, if we convert to prednisone, is about 200 milligrams of prednisone. And so to put that into context, for patients who have asthma or COPD exacerbations, they typically get 60 milligrams, and it's tapered quickly. Here we are giving a median age population in the mid-60s 200 milligrams of prednisone, 4 days on and 4 days off. Not surprisingly, people have difficulty sleeping, their sugars go up, they become irritable, which I'm sure the caregivers can attest to. And you know what led to this change was a patient advocate. He was actually followed at our center, and he was very active in patient advocacy. And he said, we have so many drugs. Why are we torturing patients with this 4 days on and off? And he lobbied for a study where they compared Revlimid with dexamethasone, the 4-day pulsing, versus once weekly. And that study showed that maybe there was a slight increase in efficacy, but really in terms of depth of response. But we caused more deaths by doing the 4-day pulsing, and it came from infections and clot. So for that reason, now that we have so many potent drugs, very few regimens use that pulse dex 4 days, and it's usually 40 milligrams once a week. Probably the 2 exceptions to that would be somebody with spinal cord compression or acute renal failure, where really there's something at fundamental risk if we don't get this disease very, very quickly. But for the vast majority of patients that are typically being treated in an outpatient setting, once weekly steroids is adequate. And for patients who are over 70, studies suggest that we can go below 40 to maybe 20 milligrams weekly. And certainly whatever we start with can be adjusted. So it all depends on risk-benefit, right? So if somebody's tolerating it well and the disease is being debulked, great. If they're having a miserable time and the disease is well controlled, maybe we can back off. And a lot of work is being done on steroid-sparing regimens as well. So stay tuned for evolution of that data. But that's how we got to where we are today.
Another, I think, question that we all struggle with, so which is better? So KRD, carfilzomib Rev-Dex, or RVD, Velcade Rev-Dex for newly diagnosed patients?
So obviously the big difference is K versus V. So there's some pragmatic issues which are different. So the administration of Velcade is in the skin. Initially, the regimens are typically twice weekly, but sometimes there's weekly. So and those are separated a few days apart. So a regimen might be Monday, Thursday, Tuesday, Friday, twice weekly, week off. Carfilzomib is given intravenously, so you need an IV put in, and it's approved as 2 days back-to-back, so days 1, 2, 8, 9, 15, 16, and a week off. So that might be Monday, Tuesday, Monday, Tuesday, Monday, Tuesday, and the week off. So inherently, there's a difference there. Are you coming in back-to-back? Are you coming in several days spread? Do you need an IV or not? So there's the administration issues. Then there's the side effect issues, which is Velcade tends to have more of a risk of neuropathy. Admittedly, with sub-Q, it's quite low, and carfilzomib does not tend to have neuropathy, but one of the side effects of carfilzomib is it can increase blood pressure, and very rarely, in less than 5%, can cause cardiac issues. So you could have kind of 2 extremes of patients, and then which I'll come back to in 1 second, and the other feature to think about is how aggressive is the disease, right? So in somebody with high molecular risk that you heard from Dr. Cole, if they have extramedullary disease, the disease is really exploding. In a head-to-head study, carfilzomib at a high dose was shown to be more efficacious than Velcade at a lower dose. So when you put all of that together, you have patient factors. So in somebody who's very concerned about neuropathy, has no cardiac profile, and does not want to get IVs, maybe Velcade's better. At the other extreme, somebody who has no, the Velcade would be better, but if somebody has a neuropathy history, they have no cardiac issues, they have very aggressive disease, maybe carfilzomib is better. I doubt we're going to see a head-to-head study with KRD, VRD because from the companies, but there's an important SWOG study that's going on, which is so sometimes these questions need to be addressed by academic and groups, and so there is a head-to-head study going on comparing those two. So until we have that data, we can't make a uniform blanket statement, but both are very active regimens, and it really depends on those features that we just covered.
I think all my patients are waiting to hear your answer on. So, can a patient become unsecretory? Should bone marrow biopsies be done routinely for follow-up in patients, or can we just follow blood levels of protein?
So I think the way to think about it is obviously if you want to follow the SPEP, UPEP, free light chains, and imaging. When you've achieved all of that becoming negative, then the question is, will the marrow change your management? So it goes back to what we tell medical students, don't do a test unless you're going to do something different with the result. So if you pushed physicians in 2017 outside of a clinical trial, tell me how my marrow will change my management, they will probably be able to come up with some responses physicians can always do. But the question is, will there be any evidence to support that? And right now, we have a dearth of data about how to change our management based on marrow results. So, and I'm specifically talking about, I'm assuming patients who are not having toxicity. For example, one place where I think it's very important to do marrow is in somebody whose blood counts are very low. And we want to really understand how much is that of myeloma and how much is it chemo and how much of it could be something else in the marrow, like the marrow functioning poorly, such as in myelodysplastic syndrome. That, I think across the bat, everybody would agree. We want to know so we can better manage the chemo. But in somebody who's in a good remission on chemo, how will the marrow change? That's a harder question to answer. And it kind of feeds into the MRD negativity state, which we'll talk about a little bit later. But I think at a high level, I would say probably if somebody's very high risk and they're MRD positive, we may consider augmenting their therapy. Again, we don't have data to do that yet. And at the other extreme, in somebody who's MRD negative and low-risk low-risk myeloma, might we consider decreasing the intensity of the therapy or the duration of the therapy because that patient, particularly if they're having side effects, to consider that. But outside of the clinical trials, we really don't have data.